they think that they're actually in those acute periods experiencing bone mineral density losses. And that's just untrue.
Nobody's safe. Nobody's safe. Nobody's safe. Soon as we step out the cage, we raising all of the stakes. Make no mistake, either you stay in your place or we putting you on a plate. Look at our
What's up, everybody? It's Boy Ryan, and this here is the Thunder Channel on nootropics, on testosterone, and on male performance. Please subscribe to the channel if you're into that kind of content. Quickly, I want to say thanks for those of you that purchased a bunch of Torque on the special. For those of you that didn't and still want a discount, I got a code for you. It's 15 now. 15 now will save you 15% on the Torque stack. Also want to mention I recently just launched the Getting on TRT guides. For those of you wanting to get on TRT or thinking about it, and all the information spread out everywhere, but you'd like information in one central source, you can get Getting on TRT at livecortex.com. All right, friends, let's discuss estrogen control on TRT and its effect on bone mineral density. And whether or not you're really looking at some sort of major reduction in bone mineral density over a long period of time, if you are one of those people that has to end up controlling estrogen or taking an AI. Now, the situation's complicated, right? Because I think there's conflicting positions on whether or not an AI is needed to reduce estrogen while you're on testosterone replacement therapy, and that's predominantly because there's a lot of laymen in the mix that are positing their positions and their experiences, which is actually very useful, but at the same time, folks, even somewhat scientific folks, have the tendency to make blanket statements like what worked for me must work for everybody, and what caused me side effects is going to cause everybody else side effects. And that's just, you can't look at things that way. There's some men that are going to require estrogen control on TRT, and then there's some men that, based on increasing injection frequency and lowering doses and kind of dialing in their protocol and doing a host of other things, that will not have to manage estrogen on TRT, at least with an AI. And as a lot of you have seen that are into this, there's like aggressive, in camps, like there's fighting between those camps. There's the people that say like you should never ever take an aromatase inhibitor anytime in your life, and that 100% you can manage estrogen on TRT by reducing your dose, changing frequencies, eating broccoli all fucking day, taking DIM, and a host of other things, which is a blanket statement, right? It's not actually true. In my consulting, I think there's anybody that's in practice, whether you're a medical doctor or you're a consultant on TRT, you've come to realize that blanket statements really just don't apply. My personal position on the matter, and we'll get to bone mineral density losses and the concerns around AIs in a second here, is that, yeah, look, if you can avoid taking an aromatase inhibitor while you're on TRT by increasing your frequency, lowering your dose, lowering your body fat, eating cruciferous vegetables, taking DIM, so you're inducing the 2-hydroxylation of estradiol to estrone, which technically has a far less affinity for the estrogen receptors, and basically all of the usual suspects, don't be insulin resistant, etc., you should. If you can avoid an aromatase inhibitor for some of the concerns that I'm going to get to, you should try to do that. Like, I'm not on either side of it at all as a consultant on the matter. Like, there's a couple things that I really dislike about AIs, which I'm going to get to, and then there's some reasons or situations in which I feel like they're necessary. The most prominent drug that, men on TRT use to reduce estrogen is anastrozole. And anastrozole works by binding to the aromatase enzymes and inhibiting them for, well, we'll get to it, but a brief period, which reduces the testosterone's conversion to estrogen. Now, guys like on TRT, usually end up taking anastrozole if they're on TRT, but, their libido is not great, or they've got erectile difficulties, or they have acne or other symptoms that we know are pretty closely tied to estrogen. And, some of those guys, a fraction of those guys that take AIs on TRT are just fine. Their libido is great. Their EQ is great. Their bloods are good. They don't have high blood pressure, next to no symptoms or no symptoms, and they just fucking feel awesome. But some men, and I think I would argue 70 plus, this is an estimation, but probably 70+% of those men are either dosing anastrozole wrong or too high or too frequently and aren't checking labs in between and doing some of the things I'm going to suggest that you do here. A certain percentage of men. I don't want to gaslight the men that have tried all these things. Hopefully I can educate you on some things you can try. Additionally, that's kind of one of the points of this video. But some men, like, whether they've tried or not, like, to minimize side effects, and anastrozole is just going to cause symptoms in them. It causes joint pain. It can cause fatigue. It can fuss with your erection function, it can fuss with your libido, and it can do a host of other negative things. But the real question is, so before we get to bone mineral density, why? Why is this happening? What all the literature points to is transient inflammation in the joints and the musculoskeletal tissue. If we look at the breast cancer studies, which are, where a lot of the research on anastrozole and aromatase inhibition comes from, in a lot of cases, it's warranted and suggested by the scientists or the authors of the study to take anti-inflammatory medication while they're dosing anastrozole to stave off some of these negatives. But all of the research on anastrozole and some of its negative effects on bone mineral density and some of these, symptomatic negatives are with women that are on breast cancer, some of whom are already osteoporotic, by the way. So that obviously plays into this, but also are on high doses of anastrozole. And we're talking about 1 milligram of anastrozole a day. But look, some men still have joint pain. And, this sort of, it's really transient arthralgia. I mean, that's the kind of phrase for this. Post taking AIs, it does happen 100%. I want to be clear, I'm not gaslighting guys. I totally understand. I've had to dose AIs myself, and I fucking hate them. But, I'm able to, in those cases, get it under control with high dose fish oil supplements that are concentrated docosahexaenoic acid and icosapentaenoic acid. And I'll get to some of the research on that in a bit, as well as a compound called strontium, which I'll explain its effect on bone mineral density and joint inflammation here in a sec. The real answer to, why do men get joint problems and arthralgia when they take anastrozole, aside from dosing mistakes as well as frequency mistakes, which I'm going to get to, you're having a rapid reduction in estrogens, particularly estradiol, and that's causing acute musculoskeletal and joint inflammation. I mean, that's what all the literature points to. So it's a real thing. It's you're not just making it up. It's a very clear mechanism for that. Now to bone mineral density. So the research on this, if you look at it from the outset, or just if you're kind of peering into it and you haven't done a whole lot of digging in and getting meticulous about it, it's scary, right? There are women who over the course of 5 years had between a 6 and 7% bone mineral density reduction in the hip and the lumbar spine. In one of the papers that I'm referring to that actually shows this definitive bone mineral density reduction with anastrozole, again, considering using 1 milligram doses, which is not what you'd be using with TRT. The authors concluded on one of these studies, anastrozole is associated with accelerated bone loss over the 5-year treatment period. However, although patients with pre-existing osteopenia are likely to require monitoring and bone protection strategies, patients with normal bone mineral density would not appear to require monitoring beyond the recommendation for healthy postmenopausal women. So what they're saying in this particular case is if you already have adequate or healthy bone mineral density, you really wouldn't require monitoring. There's also the fact that this is being done in women or studied among women and not men that are on TRT, which increases bone mineral density. So a few points to take away from here. And look, in these type of situations, there always arises a strong degree of caution, like when you're looking at a study like that. And paranoia from the TRT community, and which is entirely warranted, right? I mean, it's 100% warranted to look at that study and go, wait, hold on, that doesn't look good. I don't want that for the future of myself. And so how can I get around this? The issue with that is among the Redditors and some of the people that are postulating one thing or the other and saying, hey, anastrozole made my joints hurt, etc., and posting on it and scaring other men, is that, when they take anastrozole and they get transient joint arthralgia, they think that they're actually in those acute periods experiencing bone mineral density losses, and that's just untrue. Okay, when you dose anastrozole and you have joint pain or whatever, you're not experiencing bone mineral density losses. Again, it took 1 milligram per day every 7 days, 7 milligrams of anastrozole, which is 56 times higher than a 0.125 milligram dose once a week of anastrozole in a guy that's on TRT that has extra bone mineral density from the TRT, lifts heavy weights presumably, etc. Now, there is something to say about the way that guys dose anastrozole. I mean, I have spent many, many years consulting men on dialing in their TRT protocols, so I'm not a stranger to how all of this works. And to be clear, the problem with anastrozole, because there's many problems with anastrozole, is that, the issue stems from recommendations on TRT for aromatase inhibition using doses of 1 milligram per week, even 0.5 milligrams twice a week, which usually ends up, there's no blanket statements here, but usually ends up being problematic for large degree of guys. Also stems from the fact that aside from some nifty compounding that I have read does take place in some pharmacies where you can actually get the tablet down to a 0.125 milligram quantity per tablet, which you can then, presumably cut in half or cut in fourths and even get further microdoses. That's just not common, right? And 9 times out of 10, as an estimation, you're going to get, 0.5 or 1 milligram tablets. That's another part of the problem. You get a 1 milligram tablet and you have a pill cutter, you cut it in half, and then you got 0.5, and then you cut that in half, and you got 0.25 per fourth, and then you cut those 0.25s in half, and you're not actually getting 0.125 or whatever, right? It just becomes convoluted at that point. And yes, that's fucking tedious. It's annoying. And it's like, you guys are sitting there doing that. Like, I don't want to do this. And I understand. But I'd say this, a strategy that one should consider executing if they require a bit of estrogen reduction, because say, their E2 is above 40, they're having some estrogenic symptoms, libido, erectile difficulties, etc. Which, by the way, people go, oh, there's no study on anastrozole and TRT in men. That's incorrect. There actually is. And, in that study, the elevated estradiol was defined as between 40 and 60 picograms per milliliter, or greater than 60 picograms per milliliter. So that is a defined thing in the literature, for the record. It's just nobody that talks about, estrogen is like great and you should let it go up to 200 and leave it alone forever ever wants to reference that study, which I think is unfortunate. Anyway, if you've done everything, so if you need to get it on AI at small doses or whatever, because you've increase your injection frequency, you have executed the reduction in body fat, you are not insulin resistant, you eat broccoli twice a day, you take dindylmethane, you've gone sub-Q, you've done all these things that, are suggested to reduce test's conversion to estrogen, or at least keep it in a manageable range. What you need to do with my personal observation on what may benefit men on the use of anastrozole in those cases to get the testosterone estrogen ratio, which is something that often isn't talked about in these cases, in the right place for that individual, because it's not blanket, there's not a one-size-fits-all type of situation, so that you can gain libido back, erectile function, etc. You got to execute a strategy that encompasses not just the serum half-life, because I think people are confused about that and go, that means all of it's out of your body. It's only half the drug out of your body at the half-life point, but also the serum full clearance of the drug from your body, so that you can time the anastrozole frequency, particularly, as well as the dose, but the frequency in a way that eliminates or minimizes side effects. So the half-life on anastrozole, it's going to be different for different people. So you're looking at 2.5 days or so after your initial dose of whatever you decide to dose with. However, that doesn't mean that all the drug is out of your system and that it still isn't, reducing estrogen concentration if you're clearing estrogens correctly through your urine. And look, that can happen anywhere between 5 and 10 days. The literature shows us that with a 1 milligram dose, that between 6 and 12 days, the drug is still in the system, right? Herein lies a big part of the issue. People are looking at half-life and going, okay, 72 hours or 60 hours or whatever, I can redose. But you've got to consider the entirety of the life of the drug in your system, and how at between 5 and 10 days, 6 and 12 days, it may still be in your system, binding to aromatase and inhibiting it. So here's what men often do. Guys will have libido issues. They'll look at their E2 and, it's at 40 or 45 or something. And they're like, hey, I want to get this under control. So the mistake in this context is after 2 or 3 days of an initial dose of anastrozole and not seeing results on libido, erection quality, or whatever you postulated was an estrogenic symptom and you're trying to resolve it, the mistake is dosing again thereafter. This is primarily because I think people get half-life confused with like the entirety of the life of the drug and don't give it enough time for it to completely be out of your system, and are, guys are, men are impatient. We want to get things done. I'm not riffing on it. I think it's great. That's why we're assertive and we get shit done in life. Like we want to change things. Guys are just essentially not giving it enough time over a 30-day period, cyclically dosing 0.125 or 0.25 milligrams, or maybe even less of that, of anastrozole for the T to E ratio to balance out for estrogens to clear the system after dosing anastrozole, because that's a thing too, right? That's why you take things like DIM to essentially facilitate the metabolism of estrogens out into the urine and out of your system. I can tell you this, working with men or having worked with men that have sexual dysfunction of all shapes and sizes, It's rarely that they get better in some sort of short capacity. And even once the right regimen is achieved, it may still take time on that regimen for, their libido to come back or their erection quality to come back. Like, try to think of it like a sprained arm or something. Like, you put it in a cast. Once it's in the cast and you got the right treatment, it doesn't heal in a week, right? It takes a month or 2 months or whatever it is, and you kind of can't use it in the meantime. So ultimately, a good percentage, not all. Again, there's going to be some men that microdose anastrozole, like do all these things correctly, and it still causes joint pain, which I'm going to get to in a second. But a lot of guys are just not waiting for the actual full life of the drug to be out of the system, not getting this granular. And perhaps, I know this sounds super tedious, but after you dose your first dose of microdosing anastrozole, you may 2-3 days later want to run to, Quest, book an appointment, go to Quest, spend the $50 or whatever it is on discounted labs, and get your ultrasensitive serum E2 tested so that you understand exactly after at least the initial half-life is over how much estrogen reduction you actually got from that dose. What I would, again, say through my observation seems to be useful for a good degree of men in this sort of pickle, in this dilemma, is 0.125 milligrams, or even smaller if you can manage it with a pill cutter, of anastrozole, then waiting 7 to 10 days, considering at 1 milligram, it was 6 to 12 days before the drug was completely out of the system and not affecting estrogen anymore, right? You probably want to give it 7 to 10 days if you're trying to dial in your AI dose. So that's painstaking. Yes, your joints might hurt in the meantime. You might have some temporary transient arthralgia. And this is, I think, where a lot of guys give up, right? And they just go to Reddit. It's very easy to go then and watch some IT guy from Quebec say that aromatase inhibitors are terrible and you should never, ever take them, and that estrogen shouldn't be managed. It's easy to fall into that camp once you've had some issues. But I think a lot of the men that are executing the use of anastrozole are not doing it this granularly. But look, let's forget about all that stuff. I'll just digress out of, what you can try to do, at least as it relates to dosing on anastrozole, and get into what you can do about bone mineral density over a long period of time. So yes, we know that in cancerous women, some of whom in these studies were already osteoporotic, all of whom were taking 1 milligram a day of anastrozole, which again is 56 times the amount of anastrozole that a guy on TRT would take if you're taking 0.125 milligrams over a 7-day period. Nonetheless, over a 5-year period, there was bone mineral density loss, particularly in the hip as well as the lumbar spine. So in addition to the transient phases of arthralgia and assumed joint and musculoskeletal inflammation that is at the root of some of the symptomatic effects that men get when they take AIs, and in addition to dosing extremely intelligently, guys, if you're at that point where your estrogen's high, you've listened to the other camp, and you want to maybe try to do something about it, you really have to approach this carefully, which comes back again to the whole problem of AIs as far as compounding and dosing, is that they're just situated in tablets that are dosed far too high. Execute some of these more intelligent dosing strategies, perhaps run labs after day 3 to see where your estrogen is. Wait 7 to 10 days, even after a 0.125 milligram dose. It may take you a month or 60 days or even more to really get the frequency and the dose of anastrozole dialed in for you. At that point, if you still have symptoms, if you've done everything imaginable, right, and you're still having what is essentially rapid estrogen reduction symptoms, then your best bet is to bring in a highly concentrated, in terms of docosahexaenoic acid and icosapentaenoic acid, fish oil supplement, as seen in this piece of literature right here, which will increase bone mineral density over a long period of time, as well as aid in the joint inflammation that is probably happening in direct response to the AI, as well as a compound called strontium. Now, strontium is going to increase plasma bone specific alkaline phosphatase, and it decreases urinary hydroxyproline excretion, which in the literature prevents bone mineral density loss, and at the very least preserves bone mineral density. Okay, so a combination of those two things would be my suggestion if you've done all of these things literally perfectly and you're still having joint pain. If, of course, you're somebody that has increased your injection frequency, you've modified your doses on TRT, really tried to dial in, you went sub-Q, you eat a lot of broccoli, you take DIM, you do all these things, you're not insulin resistant, you have sub 15% or sub 13% body fat, and you still can't get E2 in a place where you have libido and good erection quality, then execute those strategies and see how you fare. That would be my overall assessment on what is a plausibly effective strategy to minimize or eliminate concerns related to bone mineral density loss, which again is not happening transiently, but it has the potential to happen over time with very high doses of anastrozole. Overall, okay, look, I don't think that estrogen management is going to contribute to large-scale bone mineral density loss, considering that it's 1 milligrams of anastrozole per day, so 7 milligrams a week, which is 56 times higher than 0.125 milligrams every 7 days, is what's contributing to bone mineral density in some osteoporotic as well as some non-osteoporotic postmenopausal women who have cancer. And considering that testosterone itself increases bone mineral density, but in still considering that and understanding that even in the smallest doses of anastrozole, symptoms can still occur in this context, which I understand. I'm not gaslighting people about again, and I think it's just really unfortunate. Some of the strategies that I laid out to reduce joint inflammation and increase bone mineral density, like high concentrated EPA, DHA, fish oil supplementation, as well as the maintenance dosing of strontium to keep bones in a healthy place, are warranted. All right, if you appreciated any second of this content, please consider subscribing to the channel. I really appreciate the fact that you're here. Hit the bell to get notified of all future content. Again, just launched is the Getting on TRT guide for those of you that are thinking about getting on testosterone replacement therapy and want a guide that synthesizes everything you need to know going into it in one digital downloadable PDF. You can get that at livecortex.com. If you need to hire me to help you dial in your protocol on TRT, you can also do that at livecortex.com. I've spent probably about 6 years working with men on TRT. Some of these nuances, like the way that I understand a lot of this stuff, at least at great detail, in stepping away from Reddit anecdotals and getting into real people kind of context, is through working with people. And that's why I'm not on either side of this, right? It's like blanket statements are not useful for any of this. You got to approach each individual individually. Anyway, you can hire me at livecortex.com. We do a bunch of other stuff related to nootropics, etc. We got 2 nootropic stacks. Torque right now, I'll give you a coupon code. Those of you that bought it 35% off or 30% off, really appreciate it. Those of you that didn't, you can still get it for cheap right now. 15% off, coupon code 15 now. Motivation, mental energy, verbal fluency, brain stimulation. Also, we have another stack called Cortex, market tested, been on the market for about 8 years. Very powerful nootropic stack that's predominantly dopamine centric. Very noticeable nootropic. You can get it at livecortex.com or down in the description below. I think today's Thursday, so we'll be doing another live stream more than likely this Saturday, so look forward to the thumbnail on YouTube where you can get notified for that. Those are always fun, where we sit for an hour and talk shop, so look forward to that. Hope you guys are having a great week. Hope you have a great rest of your week, and I will talk to you on the next one.